the winner of the Best in Research Scholarship, which has been awarded to Takahiro Arimura from Japan.
Thank you, Chairman. It's an honor to be here. My name is Takahiro Arimura. I am a graduate student at Kyushu University. Today, I'd like to discuss about the enormous impact of neuromechanical unloading therapy, which is the combination of left ventricular assist device and vagal nerve stimulation on acute myocardial infarction. Despite the widespread use of auric perfusion therapy, acute myocardial infarction remains a leading cause of chronic heart failure. There is a clear unmet need to prevent heart failure in patients with AMI. It has been well established that suppression of MVO2 is beneficial in the management of AMI. This slide shows the impact of LVAD on MVO2. A pressure volume area, PVA, is a specific area circumscribed by the endosystolic pressure volume relationship and ED-PVR and the systolic segment of pressure volume trajectory during contraction. PVA represents the total mechanical energy, and it has been well established that PVA linearly correlates with myocardial oxygen consumption. In this framework, LVAD decreases preload, whereas increases afterload by augmenting net cardiac output. So the impact of LVAD on PVA depends on the balance of decreased preload and increased afterload. So partial LVAD in which LV remains ejecting, LVAD decreases preload but increases afterload. So partial LVAD cannot greatly reduces PVA and MVO2. On the other hand, total LVAD in which LV no longer ejects because LV pressure is lower than the arterial pressure due to low LV preload. Total LVAD makes PVA extremely small. We have shown that the total LVAD markedly reduced the infarct size. Illustrated in this slide is the impact of vagal nerve stimulation on myocardial infarction. It has been established that vagal nerve stimulation has a powerful anti-ischemic effect through complex mechanisms, including heart rate reduction, and anti-adrenergic effect and anti-inflammatory effects. Despite the vagal nerve stimulation has a powerful anti-ischemic effect, technical difficulties preclude its clinical application. To overcome this problem, we developed the new intravenous vagal nerve stimulation, IVNS. We inserted electrode catheter into the supravenous cava and stimulated right vagal nerve. We hypothesized the combination of LVAD and VNS is more powerful anti-infarct effect. So the aim of this study is to examine whether the combination of LVAD and VNS synergistically reduces the infarct size and prevent heart failure in the long term. In 33 mongrel ducks, we created myocardial ischemia reperfusion model by ligating LAD for 3 hours, then reperfusion. As a treatment, we use Impera CP and intravenous vagal nerve stimulation. We created 3 hours myocardial ischemia, then reperfused. All treatments were applied in only acute phase, 60 minutes after the onset of ischemia to 60 minutes after the reperfusion. We divided all dogs into 6 groups by combination of treatments: no support, partial support, total support, respectively with or without IVNS. After acute intervention, all animals were allowed to recover. In 1 month later, we assessed infarct size and cardiac contraction and heart failure parameters. The effect of neuromechanical unloading on cardiac function and other heart failure parameters are shown. The combination of LVAD and iVNS normalize endosystolic elastance and 2D echo ejection fraction and decreased LV and diastolic pressure and NT-proBNP. Neuromechanical unloading improved the cardiac systolic function and heart failure parameters. The beneficial impact were most prominent when total LVAD was combined with iVNS. As for cardiac infarct size, relative to no treatment group, both partial and total LVAD significantly decreased infarct size. Total LVAD markedly reduced infarct size by 80%. iVNS alone decreased infarct size significantly and lower than the partial LVAD. iVNS is powerful anti-ischemic effect. Indeed, partial and total combined with iVNS further reduced infarct size, and in some animals, in total LVAD was combined iVNS, we couldn't detect the infarct size. The combination of LVAD and VNS synergistically reduced infarct size, preserved LV function, and prevented heart failure in the long term. To establish total LVAD in human, the development of high-flow percutaneous pump is essential. The device to generate more than 5 liters per minute is required. To avoid the adverse effects of LVAD and VNS, for example, sucking of LV or extreme bradycardia, optimization of regulation of LVAD pump and VNS to maximally reduces infarct size and prevent chronic heart failure remains to be seen. In conclusion, the neuromechanical unloading synergistically and strikingly reduces the infarct size and prevents heart failure in the long term. The transvascular LVAD combined with VNS would serve as a new therapeutic option in the management of patients with acute MI. Thank you for attention.
Thank you for a compelling presentation. There are a couple of questions. If we could.
So, first of all, congratulations on a beautiful job. I have a question. In the chronic support, there were multiple dog studies that show very promising result on vagal nerve stimulation by Ani Sabah and the group from Detroit. Following by that, we had multiple big studies on chronic heart failure and nerve stimulation. All of them came back to be in human negative. Is it related to the high adrenergic drive that animal got compared to humans and the difference in the heart rate? And that's the reason you see that actually iVNS in your study without any kind of LVAD was more superior to Impella alone.
I don't know exactly, but I think that in experiments I didn't see the mortality. So without animals without treatment were died or animals. But in clinical, the treatments is effective for more larger myocardial infarction.
Yeah, Nir, I think that's a great point. I think the element that's missing from these analyses are a measure of basal adrenergic activity. So obviously, if you did this in a cat versus a dog versus a pig versus a cow versus a human, you'd get very different basal tone. And so I think the thing that would have to happen is we just have to normalize to basal adrenergic tone, which is challenging, but I think you bring up a great point.
Kanji?
Thank you for this nice data. Okay.
Kanji want to answer?
Yes.
I am a collaborator of him, and your question was great. And I thought, and we thought that for working on animal study of vagal nerve stimulation, it's going to work in patients. But it never happened so far. I think there are many reasons why it does not work at all. One really serious reason is that, at least I believe that the condition of stimulation. In animals, we can scan wide variety of stimulation conditions and focus on particular point where we can get the maximum impact. Whereas in patients, if you carefully look at the protocol of stimulation, basically all protocols are directly took from animal study, like a 20 Hz stimulation, 10-second stimulation, and 50-second of pause. No one knows that that condition is optimal in patients. We don't know either. However, we know pretty well that that's almost the best in animals. So that kind of lack of optimization in human is one of the major reasons, other than the background, the autonomic nerve activities. So that is my immediate comment to your questions.
Dr. Hunsinger had a question, or maybe we should wrap up now. Actually, I have one question or comment for, more likely for the whole panel, that there's been a lot of discussion on the timing, on how long the impeller should run during ischemia. I think we need also to look at how long time the ischemia has been ongoing, because in the clinical scenario, most patients don't present within 1 hour of onset of AMI. So I think we also have to look into that.
Yeah, I think we'll be hearing comments about that a little bit later on when we have the discussion on conditioning. Great point.
Thank you, and I think we'll wrap up now and have 15 minutes break. Thank you.